Good evening, everyone. This is my presentation on implicit biases in psychological services. My name is Fatima Fidha. I'm a second-year clinical psychology major and public health social issues minor. And though I am a psychology major, I am not a professional, so this presentation is a mixture of the knowledge I have acquired as well as the research I have been conducting over this last quarter. Before I begin my presentation, I would like to do a land acknowledgement. The UC San Diego community holds great respect for the land of the original people of the area where our campus is located. The university was built on the unceded territory of the Kumeyaay Nation. Today, the Kumeyaay people continue to maintain their political sovereignty and cultural traditions as vital members of the San Diego community. We are honored to share this space with them, and we thank them for the stewardship. This is adapted from the UC San Diego Intertribal Resource Center. So here is our table of contents. A quick disclaimer, I am using closed captioning from Google Slides, so everything I say might not be accurately represented by the captioning, and this presentation is also being recorded. Y'all's faces will not be recorded, but the presentation itself is being recorded. So here's the table of contents. We will begin by explaining what implicit bias is, then psychological theories, then psychological therapies. We'll move on to psychological services, and from there, psychological services and implicit biases. And lastly, what can be done. Here is our community guidelines. So before I begin our presentation, I would like to go over our community values/guidelines. This is what I would like to see from y'all and what y'all can expect me to enforce. First, I would greatly appreciate audience participation. There will be discussion questions throughout the presentation, some of which might require you all to lean into discomfort. Second, I expect everyone to be respectful of everyone's opinions and beliefs, no personal attacks or generalizations. We must remain respectful of every single individual. And lastly, this is a brave space, not a safe space. And what this means is that we cannot guarantee that you won't be triggered by what we are discussing today. Some of our topics are rather heavy, like mental health and implicit biases. If you find yourself being triggered, please do whatever is necessary to make yourself comfortable and to make sure that you are okay. If you have to step away from the screen, that is totally fine. Please do whatever you need to do. So, to begin, what is implicit bias? Implicit biases are pervasive and robust. Everyone possesses them, and even people with avowed commitments to impartiality, such as judges, display implicit biases. The implicit association we hold arise outside of our conscious awareness. Therefore, they do not necessarily align with our declared beliefs or even reflect stances that we would explicitly endorse. Implicit and explicit biases are generally regarded as related but distinct mental constructs. Implicit attitudes may be better at predicting and influencing our behavior than self-reported implicit attitudes. Implicit and explicit attitudes should be considered in conjunction in order to understand prejudice-related responses. Implicit biases have real-world effects on our behavior. Next, psychological theories. In psychology, theories are used to provide models for understanding human thoughts, emotions, and behaviors. Throughout psychological history, a number of theories have been proposed to explain and predict various aspects of human behavior. A psychological theory must have two key components. It must describe a behavior, and it must make predictions about the future. There are many psychological theories, but most can be categorized as one of the four key types, which is developmental theories, grand theories, mini theories, and emergent theories. Developmental theories. They provide a framework for thinking about human growth, development, and learning, as well as a set of guiding principles and concepts that describe human development. To the left, there's a little comic strip with parents that are holding a government child development guide, trying to predict what their child will be like in the future. Next is grand theories. Grand theories are proposed by major thinkers such as Sigmund Freud, Erik Erikson, and Jean Piaget. These theories seek to explain much of human behavior, but they are outdated or incomplete. Psychologists and researchers often use grand theories as a basis for exploration. The picture to the left has some of the major thinkers that were mentioned earlier. Next is mini theories. Many theories explain narrow behaviors such as how self-esteem is formed. These theories are often rooted in ideas established by grand theories, but they do not seek to describe and explain the whole nature of human behavior and growth. So here's another little comic strip. And what this shows is a detailed face, and it says, "Would you have listened to me if I looked like this?" And many theories aren't as well known or popular as grand theories, which are more simplified psychological theories, so they're more well known. Next is emergent theories. These theories draw on research and ideas from different disciplines, but are not as broad or far reaching as grand theories. The social cultural theory is a good example of an emergent theory. And then here I have a little image that says everything but the kitchen sink. And that's kind of what emergent theories are like. Next, we have psychological theories. Some of the best known psychological theories focus on specific branches within psychology. Some of these include behavioral theories, cognitive theories, humanistic theories, personality theories, and social psychology theories. First, behavioral theories, also known as behaviorism, is a theory of learning based on the idea that behaviors are acquired through conditioning. Advocated by famous psychologists such as John B. Watson or B.F. Skinner or Ivan Pavlov, here is a photo of Pavlov's a famous classical conditioning experiment. In this experiment, he conditioned dogs to salivate when they heard the sound of a bell with classical conditioning. Today, behavioral techniques are widely used by therapists to help clients learn new skills and behaviors. Next is cognitive theories. Cognitive theories of psychology are founded on internal states such as motivation, problem solving, decision making, thinking, and attention. Such theories strive to explain mental processes, including how the mind processes information. Next is humanistic theories. Humanistic theories began to grow in popularity during the 1950s, when earlier theories often focused on abnormal behaviors and psychological problems. Humanistic theories emphasize the basic goodness of human beings. Some of the major humanistic theorists are Carl Rogers or Abraham Maslow. And this is an example of Maslow's hierarchy of needs, which describes the 5 basic needs that human beings have: sociological needs, safety needs, belongingness and love, esteem needs, and self-actualization. Next is personality theories. Personality theories in psychology look at the pattern of thoughts, feelings, and behaviors that make a person unique. Some of the best known theories in psychology are devoted to the subject of personality, including the trait theory of personality and the Big Five theory of personality by Erikson. Next is social psychology theories. Social psychology is focused on helping us understand and explain social behaviors. Social theories are generally centered on specific social phenomenon, including group behavior, pro-social behavior, social influence, and the effects of love, and much, much more. A famous example of social psychology is the Stanford prison experiment, which was facilitated by Philip Zimbardo. In this experiment, college students were divided into 2 groups. They were either prisoners or guards, and being placed in these groups changed the behavior of the college students, even though they weren't assigned or told to behave in certain ways. Next is psychological therapies. So right now I have a discussion question, and Nancy will also write this question in the chat, just in case anyone's having a hard time seeing or hearing me. So what do you think when you hear therapy? And I will give y'all a moment to respond. Nancy wrote in the chat, I think support, help, healing, and rehabilitation. I also think those things when I think therapy. Alejandra, I hope I'm pronouncing their name right, wrote counseling, professional one-on-one treatment, open discussion for support. I also agree. And thank you for writing in the chat. I'm going to move on from this question. If anyone still wants to write the question in the chat, please feel free to, but I am going to move on. So first, psychodynamic therapies. What is it? Psychodynamic therapies. This is an approach that focuses on changing problematic behaviors, feelings, and thoughts by discovering and their unconscious meanings and motivations. Psychodynamic orientated therapies are characterized by a close working partnership between the therapist and the patient. Patients learn about themselves by exploring their interactions in the therapeutic relationship. Psychodynamic therapies were influenced and developed from psychoanalysis, which is a long-term approach to mental health treatment. In psychodynamic therapy, you'll work with a therapist to explore the connection between your unconscious mind and your actions. This involves examining your emotions, relationships, and thought patterns. Psychodynamic therapy may be a good choice for addressing depression, anxiety, eating disorders, substance use disorders, and a variety of other conditions. Next is cognitive therapies. Cognitive therapy emphasizes what people think rather than what they do. Cognitive therapists believe that it's dysfunctional thinking that leads to dysfunctional emotions or behaviors. By changing their thoughts, people can change how they feel and what they do. The idea behind CBT, or cognitive behavioral therapy, is that certain feelings or beliefs that you have about yourselves or certain situations in your life can lead to distress. This is influenced by major figures such as Albert Ellis or Aaron Beck. It's similar to the behavioral theory, but it also addresses unhelpful thought patterns or problematic thoughts. In CBT sessions, you'll work on identifying patterns and learning more about how they might negatively affect you. With your therapist's guidance, you'll explore ways to replace negative thought patterns or behaviors with ones that are more helpful and accurate. This is good. This is a good option for addressing mood disorders such as depression and bipolar disorder, anxiety, and some symptoms of schizophrenia. Cognitive behavioral therapy is often paired with medication. Next is humanistic therapies. This approach emphasizes people's capacities to make rational choices and develop their maximum potential. Concern and respect for others are also important themes. 3 types of humanistic therapy are especially influential: client-centered therapy, gestalt therapy, and existential therapy. This is influenced by humanistic philosophers like Jean-Paul, Martin Buber, and Soren Kierkegaard. They were great influencers of this type of therapy. Typically, your therapist will help you work towards a goal of living your most fulfilling life, largely by enabling you to be your true self. You'll spend time exploring ways to grow and increase self-acceptance, along with discussing things that are bothering you or stressing you. What is this good for? Humanistic therapy can be useful for addressing self esteem issues, difficulty coping with chronic health concerns, effects of trauma, relationship issues, or feelings of worthlessness or being lost in life. Next is behavior therapies. Behavioral therapies is a action-oriented approach to mental health treatment. According to behavioral theory, certain behaviors develop from things you've learned in your past. Some of these behaviors might affect your life negatively or cause stress. Behavioral therapy can help change your behavioral response. Important contributors are Ivan Pavlov, who discovered classical conditioning, or E.L. Thorndike, who discovered operant conditioning. In behavioral therapy, they'll focus on ways to change behavioral reactions and patterns that cause distress. There are many subtypes of behavioral therapy, including systematic desensitization, aversion therapy, or flooding. Systematic desensitization combines relaxation exercises with gradual exposure to something you fear. In aversion therapy, you learn to associate the behaviors you want to change with something that's uncomfortable or unpleasant in some way. This association might help you stop the behavior. Lastly, flooding is similar to systematic desensitization, but it involves facing your fears directly from the start rather than gradually. Behavioral therapy may be a good option for addressing anxiety, phobias, substance abuse disorder, OCD, and things of that nature. And lastly, integrative slash holistic therapy. With integrative or holistic therapy, many therapists don't tie themselves to one approach. Instead, they blend elements from different approaches and tailor the treatment according to each client's needs. So it looks different depending on what your therapist or psychiatrist or whoever your mental health care provider, what they like to focus on, and also the needs of the patient. What examples of implicit bias have you seen? And then do you think they affect therapy? Nancy will write this in the chat and I will give y'all a few minutes to write in the chat. Then I will also chime in with what I think. Edwina wrote in the chat, people moving away from me in stores. This is totally an example of implicit biases. An example of that comes to my mind when I think of implicit biases is when I am, let's say, upset, and then I instantly get categorized as being an over emotional woman. I think that is totally a part of implicit biases. But we will also review more, and I'll give y'all a few more minutes to think about it. Nancy wrote in the chat, a perception that I speak good English than expected. I also agree that is someone acting on their implicit biases. And for the second question, do you think they affect therapy? I do believe they affect therapy, and that's what I'll be arguing for in the rest of this presentation, that implicit biases do affect therapy. And not only do they affect therapy, they negatively impact therapy for the mental health care providers as well as the individual seeking the help. Next is psychological services. There are many types of psychological services. They usually include some kind of assessment, intervention, consultation, program evaluation, crisis intervention and management. Again, there are many, many kinds, but today I'll be reviewing 5 kinds that are pretty broad. First, psychotherapy. And in a general term, psychotherapy is a general term for treating mental health problems by talking to a psychiatrist, a psychologist, or any other mental health care provider. During your psychotherapy, you will learn about your condition, your moods, feelings, thoughts, and behaviors. And here we have a picture of a client talking to some kind of mental health care professional, kind of organizing their thoughts, their feelings, and their emotions. Next is clinical psychology. Clinical psychology is a specialty that provides continuing and comprehensive mental and behavioral health care for individuals and families, consultation to agencies and communities, training, education, and supervision. And then it is a research based practice, really heavy on the research. So the picture right here is someone's talking and then someone's recording it and documenting. That's what I think when I think of clinical psychology, because it is really heavy on the research and what can be done with the knowledge of someone's condition. Next is counseling. Counseling is the process that occurs when a client or client and counselor set aside time to explore the difficulties that a client is facing. This may include the stressful or emotional feelings that a client has. This can enable the client to focus on their feelings, experiences, or behaviors with a goal of facilitating positive change. Here is a picture of a group counseling session. Next is psychiatry. This is a branch of medicine that focuses on diagnosis, treatment, and prevention of mental health illnesses, as well as emotional and behavioral disorders. A psychiatrist is a medical doctor, so an MD or a DO, who specializes in mental health, and they typically prescribe medicine because they have a special emphasis on medicine. And here's a picture of someone kind of directly fixing the brain. And sometimes psychiatrists try to do that with prescribing medicine. Last is coaching, guidance, or mentoring. This is more performance driven, designed to improve the behavior or the outcome of someone's life. And right here we have a picture that says advice, help, support, tips, guidance, assistance. And that is usually what you can expect when you're receiving coaching, guidance, counseling, or something of that nature. Next, what is the DSM? This isn't for the chat, this is just to get y'all thinking. So the DSM is the Diagnostic and Statistic Manual of Mental Health Disorders. This is a handbook used by healthcare professionals in the United States and much of the world. The DSM contains descriptions, symptoms, and criteria for diagnosing mental disorders. It provides a common language for clinicians to communicate about their patients and establish a consistent and reliable diagnosis. This can be used in research of mental disorders. It also provides common language for researchers to study the criteria for potential future disorders, and it also allows for revisions. Here is a timeline. DSM-1, which was published in 1952, was based off of the military system because of the World War II, and it originally only had 7 mental illnesses written down. DSM-2, which was published in 1968, still had criticism over the validity and reliability. However, changes to the DSM-2 included 11 major diagnostic categories. It added over 185 total diagnoses for mental disorders. Additional attention was given to children and adolescents in the DSM-2, and in 1974, it was updated, and the 7th printing of the DSM-2 no longer listed homosexuality as a disorder. The DSM-3, which was published in 1980, dramatically changed the field of psychology. The 5-part diagnostic system is still used today, which first appeared in the DSM-3. The DSM-3 provides specific diagnostic criteria for over 265 diagnoses. The DSM-4 was published in 1994. This edition was more research-based as far as criteria and diagnoses are concerned, and it had more than 365 diagnoses. DSM-5, which is what we currently use, and the most updated version, which was published in 2013, lists more than 500 mental disorders, categorical information that ranges from dimensional information, which can rate how severe a client's symptoms are and how dysfunctional a client is across various dimensions. The reason I brought up different kinds of psychological services and the DSM-5, and even different theories and therapies is because they're all connected and codepend on one another. The Historically, they haven't included QT BIPOC, so queer, trans, and Black, Indigenous people of color. When considering how professionals diagnose individuals, it is important to think about who were they initially trying to serve, what preconceived notions did they already hold when they were making this manual, what are they doing to address the discrepancies in the classification system? And to bring this all together, I will be playing a video by the that features the California Surgeon General Nadine Harris and her struggle to properly diagnose patients. Dr. Harris is a pediatrician. She wanted to help children. During that process, though, she discovered that the biggest determinant of a child's health wasn't how much they exercised or what they ate. It was the amount of trauma or adverse child experiences they had been through, also known as ACEs. This is significant because most trauma can be linked to actions that relate to implicit or explicit bias. The video itself is 18 minutes, but I'll be showing a clip that's roughly 4 minutes long.
And you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand, better than we ever have before, how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response.
I'm going to end right here. This video is really awesome, and I would recommend, if you're interested, to watch the entire thing. You'll learn a lot. But I ended the video on this note that I believe was very important, that stress and trauma directly affect our health regardless of the decisions that we make. This is extremely important because it's also the same for implicit biases. Implicit biases and the way that other people may treat you can also have a negative and dangerous impact on your health, regardless of the behaviors that you make, the behaviors and the decisions that you make. So up next is implicit biases and psychological services. Implicit biases influence healthcare professionals and our overall health. Implicit biases affect the way mental health care professionals administer their treatment. This can look like a misdiagnosis because of preconceived notions or behaviors and actions that are off-putting or damaging to a patient, so that the patient may worsen, their condition may worsen, or they may no longer want to receive therapy or the healthcare that they're currently receiving, as well as overall health. The outcomes of implicit biases, such as microaggressions or full-on aggressions, can lead to trauma, which affects our brain and then affects our overall health. And what is exciting about this to me is that new research is emerging about how trauma such as racism is affecting our health. And up next, to kind of bring that together, is the DSM-5 racism as trauma. Many ethnic and racial groups experience higher rates of PTSD, post-traumatic stress disorder, as compared to white Americans. One explanation for this is the experience of racism, which in itself can be traumatic. Racial trauma may merit a DSM-5 diagnosis of PTSD, where there is an identifiable index of trauma. The DSM-5 limits what can be defined as a traumatic experience to direct exposure to physical and sexual violence, and including death. The nature of trauma, if they decide that the nature of racism doesn't meet trauma, the DSM-5 criteria won't be applied. However, PTSD related to racism may be diagnosed as a ICD-10 criteria, which means internal classification of disease, which means that the health effects of racism might be considered a disease, which has positive and negative effects. Up next, I have a video that is approximately 3 minutes long. It is called How Does Implicit Bias Affect Healthcare? It is by the Institute of Healthcare Improvement, IHI, and this neatly summarizes how implicit biases affect the healthcare system overall.
So in healthcare, bias comes in various forms. And I would say there's three primary ways that we could actually track bias. One, of course, is in interpersonal interactions, let's say between a patient and a provider. So the unconscious ways that we may have associate certain groups, certain gender identity, people with certain gender identities, people from certain racial or ethnic backgrounds, manifests in the diagnoses we're making, the interactions we're making with the patients, as well as the warmth with which we're working with them, which impacts the amount of trust that they have in the providers themselves. How does that manifest? One of the major ways that's been studied and shown and reported over and over again is pain management. So patients with darker skin, African Americans, receive lower dosages of pain medication across the board, from infants to the elderly, for the same types of ailments they come to practitioners for, because of assumptions that are being made around addiction or their ability to actually be truthful around what they're experiencing. The second way bias really plays into all of this, particularly unconscious bias, is the internal dynamics of organizations, how employees and staff members communicate with one another, team collaboration, team dynamics, but as well as performance reviews, reviews around compensation, who gets to be promoted, who gets to be a leader of an organization, of a team, based on assumptions that we may have about those people, purely based on phenotype, their origins, whatever that may be. And the third way bias really plays out in healthcare, and this is quite well documented across the board, is its costs, wasted costs. So racial bias, just one particular identity that we're concentrating on, costs the US economy, the healthcare system, $310 billion a year. And for me, I just want to think about what can we do with that money if we didn't have bias in the world.
I really enjoy that video because I feel like it neatly summarizes some of the main effects of implicit biases in the healthcare system. Next is the difficulties of combating implicit biases. First, I would say awareness. Awareness of implicit biases are are difficult to combat because it is sometimes difficult for individuals to catch their implicit biases and to also be aware. Additionally, it can take some time or work for someone to believe that they have or that they display implicit biases, since that's not our inherent belief or how we think. Implicit biases don't always reflect how we think. Next is statistical evidence. Implicit biases are hard to record or measure because because of that, research and in experiments, it can be difficult to map the effects of implicit biases. And it is also difficult to give the effects of implicit biases the validity that they deserve because it is difficult to measure. And lastly, amendments. For amendments to occur, we need awareness and acknowledgement that implicit biases do affect people's health. But for that to occur, we need awareness and statistical evidence. So there's this kind of difficult loop. However, things can be done. So, what can be done? Given that biases are malleable, they can be unlearned. Debiasing is a challenging task that relies on construction of new mental associations. It is also important to emphasize the need for repeated practice and training so new implicit associations may stabilize over time. Some individuals might think repressing biases is a way to combat implicit biases, but it is not. Debiasing is not simply a matter of repressing biased thoughts. Research shows that suppressing automatic stereotypes can actually amplify these stereotypes by making them hyper accessible rather than reducing them. I have an analogy from Anthony Greenwald and Mahzarin who are researchers that have been studying how the mind operates in social contexts with other people for over 30 years. They use the analogy of a stretched rubber band when discussing how debiasing interventions must consistently be enforced. They wrote, like stretched rubber bands, the associations modified, likely soon return to their earlier configuration. Such elastic changes can be consequential, but they will require reapplication prior to each association on which one wishes them to be in effect. In their book, Blind Spot Hidden Biases of Good People. It's a really good book. I would recommend it. There are also debiasing techniques that can help. First, building new associations, counter stereotypic training, in which efforts focus on training individuals to develop new associations that contrast with the associations they already hold through visual or verbal cues is extremely helpful. Another way to build new associations is to expose people to counter stereotypic individuals, much like debiasing agents. These counter stereotypic examples possess traits that contrast with the stereotypes typically associated with a particular category, such as male nurses, elderly athletes, or female scientists. Next is education efforts. Education efforts aimed at raising awareness about implicit bias can help debias individuals. The criminal justice system, for example, provides several techniques that have helped judges, and this can also be embraced and applied in the healthcare system. Next is having a sense of accountability that is the implicit or explicit expectation that one may be called to justify one's beliefs, feelings, and actions to others can decrease the influence of bias. And what this kind of looks like is perhaps calling someone out or asking them to explain what they meant by that so that they can realize that what they said, that thought or belief, is biased. Next is receptivity, taking the perspective of others has shown promise as a debiasing strategy because considering contrasting viewpoints and recognizing multiple perspectives can reduce automatic biases. And lastly, deliberative processing. Engaging in deliberative processing can help counter implicit biases, particularly during situations in which decision makers may face time constraints or a weighty cognitive load. Medical professionals in particular are encouraged to constantly monitor their efforts to offset implicit biases and stereotypes. And as a final discussion question, what ways do you think biases can be addressed, or what debiasing approach seems the most effective to you? And I will give y'all time to write that in the chat. When I think of a debiasing technique that works really well, I often think of intergroup contact. I also believe it can be a dangerous technique for the individuals who are in contact with someone that holds the bias or the stereotypes. However, I do think it works really well because you are forcing yourself, or the individual is forcing themselves, to think about their stereotype and then break it within that moment. And they're consistently breaking it when they're in the presence of someone who breaks that stereotype. Edwina wrote in the chat, asking questions of folks about what something they said means. This is also an effective measure, and it can help them also realize that they've done something biased, because implicit biases aren't always what we believe inherently. We do them implicitly. So if you ask someone, can you explain that? Then they might say, oh, wait, I acted on my own implicit biases. Alejandra wrote, I think having an open but respectful discussion can help with debiasing. I also think probably the deliberative processing seems the most effective to me because we can all be critical about our implicit biases. This is true, and it's highly recommended for doctors to practice deliberative processing. Thank you. And that would conclude my presentation. If anyone has any questions, please write them in the chat. Here is the Cross Cultural Center's info, our Facebook, our Instagram, our YouTube, as well as our website. If anyone is interested in rewatching this video or recommending it to a friend, it will be posted on our YouTube page. Next, we have a QR code and as well as the link to a survey and a opportunity to win a prize. So if everyone could fill out the survey, that would be greatly appreciated. I'll be on the survey slide for a few moments, then I'll move on to the next slide. Here is a sneak peek to our upcoming programs that are happening winter quarter. In 2 days, we have the roller skating and anti-Blackness presentation. To register, the link is tinyurl.com/roller skating, but with an 8. Next is an upcoming SIP about reimagining foster care for vulnerable youth. And we also have a SIP called Language Barriers, the Hispanic Community versus Healthcare Providers, which is week 10. The roller skating and anti-Blackness presentation is this week, week 8. Reimagining foster care for vulnerable youth is week 9. And language barriers, the Hispanic community versus healthcare providers is week 10. And SIP means a student-initiated project. And what this means for us as interns is that we, the interns, we choose something that is related to our intended field or our major, and we research about this topic alongside with professors. And from there, we make a presentation about something we're interested in. My major is clinical psychology, and I have a minor in public health and social issues. So I did my SIP about implicit biases in psychological care services. It kind of ties into both. Psychological care services relates to the clinical psychology side, and the implicit biases and the way that affects health relates to the public health and social issues minor. And lastly, just in case anyone is interested in where I got my information from, here is a QR code as well as a link to the sources that I used. And that concludes my presentation. If anyone has any questions for me, I will stay on the Zoom webinar for a few more minutes. Thank you for attending and participating. Our link tree was also put in the chat. Our link tree can to everything we have, our website, our Instagram, our Facebook, all in one place. So if you're interested in checking out our link tree, it is in the chat.